This is the C. Jason podcast. Hi, my name is Benjamin Bowe. I am an epidemiologist at the Clinical Epidemiology Center at the VA St. Louis Healthcare System.
Hello, I'm Miao Cai, a biostatistician at the Clinical Epidemiology Center at VA St. Louis Healthcare System.
Hi, I'm Ziyad Al-Aly. I'm the Chief of Research and Development Service and the Director of the Clinical Epidemiology Center at the VA St. Louis Healthcare System. We are here to talk about our recent paper, Acute Kidney Injury in a National Cohort of Hospitalized United States Veterans with COVID-19. Now, COVID-19 is associated with higher risk of hospitalization and mortality and higher risk of acute kidney injury. But so far, studies about AKI in COVID-19 patients were limited to regional health systems. Miao, would you please tell us how you approached the idea of developing a national study to examine AKI in COVID-19?
Sure. We used data from the U.S. Department of Veterans Affairs to build a longitudinal cohort of 5,200 U.S. veterans hospitalized with COVID-19 between March and July 2020. We described the timing and the severity of AKI and the extent of kidney recovery by time of discharge. We studied risk factors for COVID-19 associated AKI and analyzed healthcare resource utilization and the risk of death. We then look at geographic and temporal differences in the rates of AKI in our cohort.
And Benjamin, what did we find?
Among U.S. veterans hospitalized with COVID-19, nearly a third had an AKI, of which a tenth received kidney replacement therapy. The majority of participants had an AKI within a day of their hospitalization, and nearly a half of participants had not recovered to baseline serum creatinine by discharge.
Now, this may suggest that a large number of patients are coming into the hospital already with kidney injury, and that a large number of patients left the hospital with unresolved AKI. These patients may need long-term care and could suffer long-term consequences.
Yes. We found that health outcomes were substantially worse in those that had an AKI, including rates of mechanical ventilation, ICU admission, length of stay, and mortality, and outcomes were worse with more severe AKI. Several factors were associated with AKI, including Black race. We also found that Black people had a higher risk of death associated with AKI than whites.
Miao, what about geographic and temporal differences?
We observed quite a big difference in the rates of AKI across VA hospital systems, ranging from 10% to 56%. But perhaps as a silver lining, AKI rates declined by about a third, from 40% in March to 27% in July. In both instances, the variability in AKI rates were strongly associated with percent of population being treated that was Black.
So in sum, AKI is common. It happened in about a third of COVID-19 patients. Blacks had a higher risk of AKI, and the risk of death associated with AKI was higher among Black people. There was substantial geographic variation in rates of AKI, and that rates were much higher in hospital systems that cared for more Black people. A silver lining was evident in that rates of AKI appear to be dropping. And we hope that our results may help inform efforts to optimize the ongoing management of this global pandemic and the planning for long-term care needs of COVID-19 patients who experience AKI.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.